Let's see how do we position the patient. So this is the patient's position. We position in the left lateral decubitus over the edge of the table so that the movement of the probe is not restricted. After that, we talk about the anesthesia. So we require 1 to 2% of anesthesia, lignocaine 5 ml on either side of the midline, and in a saturation biopsy we may require a more amount of local anesthesia. Now we'll talk about this anesthesia details here in this systematic review. This is a systematic review which is the most effective technique for a local anesthesia if we are undergoing a transrectal ultrasound biopsy. So if you look at this, the most commonly used local anesthesia technique for a prostate biopsy is the periprostatic nerve block. And if we look at this EAU guidelines, even the EAU guidelines recommend the periprostatic nerve block as the standard of care. But there are other prostatic anesthetic techniques which have been compared, and it has been found that in an outpatient basis, if we are performing a local anesthesia, pelvic plexus block has been found to be more effective than the periprostatic nerve block. So this is important, but we most commonly use the periprostatic nerve block. So we talk about the prostatic nerve block, and the landmark is at the angle of the prostate and the seminal vesicle. There is the prostatic nerve plexus lie. We'll talk about this subsequent slides also. Now the pelvic plexus block, it's much lateral. It's lateral to the apex of the seminal vesicles where the pelvic plexus lies. There we point the needle and inject the local anesthetic. Now let's talk about the periprostatic nerve block. So this is the Mount Everest technique where we inject the local anesthesia at this angle between the prostate and the seminal vesicles. So this is the angle here. We can see that between the prostate and the seminal vesicles, there we direct needle tip, and there is the point where we inject the local anesthetic. This is another technique also done in the sagittal plane where we first proceed the tip of the needle towards the apex of the prostate, then gradually withdraw it till we feel loss of resistance of the gland. Here in the fascial planes, we inject about 5 to 10 ml of local anesthesia, and we can see them trickling towards the base of the prostate. We can see that in the ultrasound, the hypoechogenicity of the anesthetic drug passing through it, and we give it on either side of the midline, and that's a very easy technique of local anesthetic. Now, having anesthetized, we look at the biopsy gun, which takes about 1.5 centimeter of the core tissue, and it's an 80 gauge needle that we use. They're the widest biopsy schemes. We started on the sextant biopsy, which is not recommended anymore because it does not detect the clinically significant cancers adequately. So we have now shifted from the sextant towards the 12 core prostate biopsies, which also biopsies the far lateral zones as well as the apical zones. So it's very important to understand the importance of a 12 core biopsy than a sextant biopsy. So what does the EAU recommends? At least 8 biopsies has to be performed for a gland of 30 cc. But if the gland larger than 30 cc, at least 10 to 12 cores has to be performed in larger prostates. When do we biopsy a transition zone? Does it really help? Yes, in the gland which is more than 50 gram, there can be 15% detection rate of cancer more if you biopsy a transition zone. And similar vesicles, we don't have to biopsy in every patient, but if there is a high PSA and if there is a palpable abnormality or if brachytherapy is being considered in those patients, we may require seminal vesicle biopsy. So we have done the biopsy. Now this is a very important AUA biopsy specimen handling technique, and the biopsy technique very beautifully they mentioned that it's 10 to 12 cores only, which increases the CDR, that is the cancer detection rate, compared to the traditional sextant sampling techniques. And it's the 12 core biopsy technique. It also does not increase the detection of insignificant cancers. So the more number of cores beyond 12 if we take, it does not increase the cancer detection rate. It only causes more complications, more infections, but it does not increase the cancer detection rate. And also it does not over detect insignificant cancers. Now, having taken the biopsies, we have to handle the specimen very carefully and make sure that it's dipped in 10% formalin. No more than 2 cores should be placed together in one container. So how do we label the biopsy specimen? It's not necessary all the 12 cores need to be sent separately. We need to send them as per the AUA recommendation, which says you either need to send them in an 8 container or 6 container. This is how it should be labeled. And all the far lateral zones on either side should be sent together. The apical zone on either side should be sent together. This is what the AUA recommends. Also, in the 6 container technique, you send the basal of one side, basal of the other side separately. the middle lobe biopsies on either side separately and the apical of either side separately. This is the 6-continuum labeling type. We can use any of them. So not necessary 12 cores need to be sent separately. So we'll move on to the complications, which is very important. Out of the most common complication is the hematospermia. And hematuria is seen in about 15% of the patients. If we talk about the infections, all these are infectious complications: prostatitis, fever, epididymitis. They're all the infectious complications. So altogether, they're less than about 2.5%. If we look at the systematic review of the complications, so we can see they talk about a lot about the infectious complications. But apart from the complications that we have seen in the previous slide, there are other complications, infectious complications, which are possible, like meningitis, vertebral osteomyelitis, and even sepsis and septic shock. And the hospital admission rate is about 0 to 6%. 6% is not less. The hospital admission rate for a prostate biopsy being a 6% is not less. So this is what has compelled the EAU and the urologists to think about the rising infection rate, and some authors have even compared these infections to be superbugs, which is responsible for such high admission rates, and some have suggested that this is the reason why we have to shift towards a transperineal biopsy. So the infection rates in a transperineal biopsy is almost near negligible, and also there are 40 to 70 times less infection rate compared to the TRUS. This is a wonderful article in a British Journal of Urology. So are we shifting towards the transperineal biopsy because of the infection rate? Yes, some authors have condemned the transrectal biopsy by calling it a transfecal biopsies. And yes, it's not the only reason why we are shifting towards the transperineal biopsy. And there is also more cancer detection rate. It's also the histological outcomes, like the cancer detection rate is also about 60% in a transperineal biopsy. And this, and though some articles say that the transperineal biopsy has almost the identical cancer detection rate, but as we compare the cancer detection rate in anterior tumors, definitely the transperineal biopsy is more advantageous in an anterior tumor compared to a transrectal biopsy. So the transperineal biopsy detects about 40% of the anterior tumors, but a transrectal biopsy, 80% of the anterior tumors are missed. So this is important reason why we are shifting towards the transperineal biopsy. Why? Because one reason being the less infection rate, and the second is cancer detection rate being more, especially for the anterior tumors. So what are the techniques for a transperineal prostate biopsy? There are three techniques mainly: freehand transperineal prostate biopsy, the template guided biopsy, and a robot guided biopsy. We are going to talk about the freehand prostate biopsy. See, the main problem what we have when we discuss about the transperineal prostate biopsy is about the anesthesia. Most of us used to think that is the general anesthesia is the problem, but nowadays there are not the general anesthesia which hinders the transperineal prostate biopsy. We have come up with the transperineal prostate biopsy under local anesthesia, and this is how the local anesthesia is given for a transperineal prostate biopsy. There are two main techniques. The first being the pudendal nerve block, which is given just medial to the ischial tuberosity. The other finger in the rectum guides the needles, and it blocks the pudendal nerve just outside the Alcock's canal. It blocks both the superficial and deep branches. It blocks the main trunk of the pudendal nerve. But the problem with this pudendal nerve block is it might cause intravascular injection because the pudendal vessels are very close related to that. The anesthesia of choice is the periapical triangle block for a transperineal prostate biopsy. The periapical triangle block is given to anesthetize this area, this whole area, as we have seen in the yellow color. This is the area which requires anesthesia, whether we perform a freehand or a template guided biopsy. This is the area which has to be anesthetized. Now, if you look at this red dots, these are the areas of puncture of the needle if we are doing a freehand prostate biopsy. This is the whole area which is involved in a template guided biopsy. You'll see in the subsequent slides. Now, this is the landmark of the periapical triangle, the boundaries of the periapical triangle. On one side, it is bounded by the external anal sphincter, on the other side by the levator ani, on the other side by the rhabdosphincter of the urethra. So these are the boundaries of the typical triangle, and where we insert the needle tip. The ultrasound probe remains in the rectum, and the needle tip is guided into this triangle, and we inject the local anesthetic there. This is the method of choice if we are performing a transperineal prostate biopsy under local anesthesia. So it's important that we know these landmarks. Now, If we look at the freehand transperineal prostate biopsy, these are the marks which we already seen. We inject the local anesthesia from there, and we perform the prostate biopsy from those sites, like from those two sites. But the problem is the patient might have more pain because of the every time you're inserting the needle. So this precision point transperineal access guide has come, and this device sits on the transrectal probe, and this little tip is inserted inside the perineum so that every time we don't have to puncture the skin with the biopsy gun. We might change the position after a few biopsies, but it will not puncture the skin every time. So this precision point device is also a type of freehand device, which is better than the absolutely freehand random technique. Now, if we talk about the template guided biopsy, we have to understand this template, which is mainly a brachytherapy template, where 8 into 8 centimeter template, which is placed on the perineum. The scrotum is lifted upwards, and we place this on the perineum, and we can see that the local anesthesia is being given here. And after the local anesthesia, this template is placed. This whole area needs to be anesthetized, as we have seen previously. So it's slightly challenging to anesthetize a bigger area, but this template guided biopsy is important, especially if you're performing a saturation biopsy. This is one of the limitations of this, that the bony pelvis will come here, but it doesn't interfere much with the sampling because we have to sample the peripheral zones. And so we'll see in the subsequent templates that it does not interfere with the biopsy. So template guided biopsy, there are different templates. One is the Barzell technique, where we sample around 32 to 64 cores, and Ginsberg protocol, where we sample 28 cores. And basically it's the sectors which is mentioned. It's the 12 sectors. We'll see in the subsequent slides how the sectors are decided. It's a 10 sector template, there's a 12 core template. So these are the different templates. Now look at the Barzell technique. What we take is where we take samples from 8 sectors. So it's an 8 sector template, but we take about 4 to 8 cores from each sector. So it's important. So this A stands for apical, and this B stands for basal. So we take 4 sectors from the apical, we take 4 sectors from the basal, and we divide them into 4 quadrants each. And from the apical, we take from the right anterior, left anterior, right posterior, left posterior. So all those 4 quadrants from the apical lobe, we take 4 to 8 biopsies from each quadrant. So from the apical itself, we are taking about 32 cores. From the basal, again 32. So it's about how many cores we have discussed is around 64 cores. Up to 64 cores we take from this Barzell technique, but we don't require so many cores. Okay, we can reduce the number of cores to 32. We can reduce it further. So Barzell technique, basically this used to be used for when we had to get saturation biopsies. Now this is a 10 sector biopsy template. Again, we can see that we take biopsies from the different sectors. Similarly, this is the Ginsberg protocol technique. So in this template, we take 4 biopsies from the apical, 4 from the anterior, 4 from the mid sector, 4 from the posterior sector. So we take 12 cores from one side and 12 cores from the other side. So we take 24 cores total. In a Ginsberg protocol, how many cores is taken is 24. And we basically take from anterior, mid, and posterior aspect of the gland. So every part of the gland is sampled well, and there is a less chance of missing out a cancer from the peripheral zone also. So we mainly biopsy the peripheral zone, and this includes most of the clinically significant cancers. So this is a 12 core technique where we just biopsy the peripheral zones mainly. Anterior, 4 cores from here total. Posterolateral, again 4 cores from the peripheral zone here. Again 4 cores from here, posteromedial. So this is important, mainly the peripheral zones. But if the patient is under active surveillance, we take 2 cores extra from the transition zone. Most of the biopsies are taken from the peripheral zone. As we have discussed already, the peripheral zone is the most important site for prostate cancer. Just compare the transrectal versus transperineal biopsy. And transperineal biopsy, there is a very less risk of sepsis, and we don't require fluoroquinolone prophylaxis for that. And the urologist has a stable platform during the biopsy. But most of the urologists are not familiar with them. That is the problem with the transperineal biopsy. We can do it under local anesthesia. Mainly the urologists are not familiar with it, and there are higher rates of urinary retention because you're dealing very close to the urethral sphincter. So this is the pros and cons of the transperineal biopsy. So having discussed the pros and cons of transrectal biopsy and transperineal biopsy, and the advantages of transperineal biopsy over the transrectal biopsy, and the guidelines suggesting transperineal biopsy as the first choice. We would still like to conclude that even in spite of all the advantages of the transperineal biopsy, even though the recommendations suggest transperineal biopsy to be the first choice, the transrectal biopsy is not going to be replaced totally by the transperineal biopsy. The reason being, it's not because of the new ideas, it's because of the difficulty in shifting from the old ones. And even we conducted a poll among the urologists that what would they themselves prefer to undergo if they had to undergo a prostate biopsy, and 86% of the urologists preferred to undergo transrectal biopsy than transperineal biopsy, only 12%. So we are still in an era of transrectal biopsy because most of the urologists are familiar with it because it's a quick procedure and relatively cheap. So we are still in an era of a transrectal biopsy. All this while we have been talking about systematic biopsy. We'll talk about the fusion biopsies in the next video. So this is all about the transrectal biopsy and the transperineal biopsy, but we can fuse them with the MRI, and we have the MRI fusion techniques. We'll talk about them in the subsequent video. For this video, we'll be discussing about, so if we quickly recall, we have discussed in brief about the normal anatomy, and that normal anatomy is not that normal. We have discussed about the anesthesia methods, the antibiotic prophylaxis, and the technique of the transrectal biopsy, and why we are shifting towards a transperineal biopsy, and the three important methods of the transperineal biopsy, and that transperineal biopsy can be performed under local anesthesia. Stay tuned for the next video on MRI transfusion biopsies, which we're going to discuss in the next video. Thank you for your patient listening.